time. And I would like to invite Dr. Fouladvand just to present application of access stent in acute coronary syndrome. This is a lecture which is provided for this round of Data Medical's official presentation of Centers for Bulgaria.
Thank you very much, well, anyway, thank you very much for this opportunity to be in front of you. And I will try to, it's difficult to write and to talk, to be very quick looking at the time that we are going we are very late with the time. So, I will talk about the dedicated stent, especially this dedicated stent action, which is self-expandable and drug eluting, and I don't know how many of you are going to have experience with this stent AXXESS. Generally, people are experienced with its use in the normal bifurcation, but in my case lab we got further and we are using it in the acute coronary syndromes and myocardial infarctions. All of us know that the problem with the stenting during the stenting, during the thrombosocclusion of a vessel, is the difficulties in the stent diameter, because we have some problems with the vasoconstriction and thrombus burden and catecholamine stimulation and many other things that it's possible to have a stent undersized. I'm talking about a vessel, not a bifurcation during the infarctions, undersized or malposition, and this can lead to some stent thrombosis. As vessel constriction, thrombus burden can be a cause of not well choosing of the stent as a diameter, and this can lead to the malposition. To overcome the problem, we are using stent overexpansion that I think many of us do not like to do during infarction, because especially with a perfect result without post-dilatation, and we have distal embolization or even no reflow. Some other solutions are the drug self-expandable stents, especially stentis and its drug-eluting variants. The results from apposition are quite, so there are good results, but we know that with stentis it's good to perform a post-dilatation, otherwise we have a bad TLR after in the follow-up. So, I know I'm saying that provisional stenting is the perfect choice during the stenting. Even if you have a bifurcation, it's a first choice. But if you have to use two strategies, then you have the excessive metal on the carina side, and the presence of the residual thrombus may increase the risk of stent thrombosis, just in the case, you know. So the objective of this small number of patients that I have is that to evaluate if the thrombosocclusion during the stenting involving the major bifurcation can be treated with the bifurcation dedicated stent, which is self-expandable and drug-eluting. So I will show you an example. This is a lady came to my hospital with inferior infarction, 80 years of age lady, with a previous bypass from the Lima LAD and aorta to the marginal branch, and ECG, as you see, inferior infarction and third degree BAV. So the angiography was performed to the femoral approach because of the bypass. So the left anterior descending was occluded, the marginal was occluded. The two bypasses were working, and as you can see, is that pointer? This is the pointer. And as you can see, the right coronary artery was occluded at its distal part. So the treatment was angiox. I'm using angiox in all my patients with infarction intracoronary, and then intravenous infusion. Ticagrelor, cyan blue as a wire. You can see the passing of the wire and the thrombus, then thrombus aspiration and predilatations. because of the presence of the ostial stemness here, there was dropping of the pressure with the catheter where it was inside. Anyway, after the thrombus aspiration and spread dilatations, the result was that. I think it's not a good result. I mean, to decide whether to stent or not. So the problem was to stent now or the next day. You know that sometimes you can leave the patient with this flow for the next day and then to stent it. The problem was to put a base of bare metal stable and balloon expandable, self-expandable, or dedicated bifurcation. So I decided to stent it now, to put a desk, to put self-expandable and dedicated stent. What were the problem? I was with the 6 French, and you know that AXXESS is a stent that requires a 7 French catheter. If you're using radial approach, you can use a sheetless catheter. So I decided to put AXXESS over the 6 French guiding catheter, removing the second wire. So you have to be careful with the suction effect bubbles, like in the carotid stenting. When you're putting a carotid stent, you have to open the side connection because to remove the bubbles, because there's a suction effect. Anyway, you can see the coming of the AXXESS here in the bifurcation, and here you can see the correct positioning of the stent and opening of the stent, how it engages the bifurcation, the both vessels with these 3 markers that are in the 2 vessels. And here, well, there's a temporary pacemaker because of the buff. And here you can see the final result in this old lady. I think the result is quite good. 1 stent, no dilatations, and quite good result in this case. So with no reflow, slow flow to do a normal stenting, post-delay, you don't know what happened with the second branch. So that was a good decision. I mean, not a perfect decision, but it was not a bad decision. My experience in these years are 10 patients, but a little bit more because these are the number from up to the 2013, so we had some more patients in the STEMI patients, and the distribution of the vessels, LAD in 5 patients, circumflex in 2, and right coronary artery in 3 patients. In all these patients, we used a self-expandable AXXESS and angios, as I said, intracoronary and intravenous infusion with tigagrelor and aspirin as a double anti-aggregations. In all patients, almost in all patients, I'm using adenosine quite much after thrombus aspiration, after the predilatations to have a good flow and lower thrombus aspiration in both vessels. And once achieved a good result after the predilatations, and once achieved a good TIMI flow, which means 2-3, I placed the AXXESS in bifurcation with no post-dilatations. I will show you another case, which is a man with anterior infarction and complete occlusion of the LAD, no previous disease, and LAD occluded. So after placing of the 3 wire, because there was also the circumference very close to the ostium, so it's good to put another wire. So wire the diagonal of the LAD after the retention of this vessel and thrombus aspiration and SCA. I'm not mentioning the wires used there. So this was the result after thrombus aspiration and SCA. It's a slow flow, but the lesion at the bifurcation was there. So I decided to put a provisional staining. Maybe I will have a problem with the diagonal branch. As I have a good experience with AXXESS, I decided why not to put AXXESS here. And here we can see passing of the AXXESS inside of the catheter, engaging the carina, and here is the initial opening of the stent while you push it, and how to engage quite well the carina, entering quite well inside of the diagonal and the LAD. And here is the final result without no post-dilatations, acceptable result. I mean, if you do a post-dilatation in these cases, the probability to have a bad flow is quite much. So it's not a bad decision to put in this type of patients if you have AXXESS. Look how inside of the carina is the stent. I mean, this stent covers at least 3 millimeters of the carina if you put a 40 millimeters stent. So the distribution of the stents we used in our patient were 3 11 millimeters, because there are 4 types of access. The length is 11 and 40, and the diameter is 3 or 3.5. So we had more patients with 40 millimeters because in the myocardial infarction, when you are working with a 6-bench and you have to remove the wire, it's better to use a longer stent, because the distance when you open the stent up to the point of no return gives you much more flexibility to work with 40 than with 11. And there were first patients with the myocardial infarction at 3 in the night, at 2 in the night. So it's better to work with a longer one when the length of the vessel permits that. Success was perfect in all patients and no complications. I'm going to finish with the third artery, which is the circumflex artery, and you see here the patient with a bifurcation lesion of the circumflex and occlusion of the marginal branch, first marginal branch, inferior bilateral stemming. Once open the artery with the thrombus aspiration, POVA, and treatment of the bifurcation with the balloon, I decided to place here an access. This is a radial approach with a sheetless catheter. You can see how the stent enters inside of the. It's a bulky device, but with a good catheter and a good support goes everywhere. Just a little bit, a little bit experience. I think it's absolutely enough. So you see that yesterday. And here is the stent in this case inside of the initial opening of the stent involving the both branches, and here is the opening of the stent, final opening of the stent. And here I can show you the final result after, obviously, in this case, stent of the marginal branch of another stent placed exactly at the end of the stent axis. But the carina is not over engaged with the metal, and the carina is free, and the distribution of the flow is physiological. So I can make my conclusion, I think it was quite quick in this case. So axis characteristic, the stent axis characteristic is a tracheal looking, self-expandable, and it's bifurcation dedicated. Could be taken into consideration, not saying put it in all bifurcation during infarction, maybe better first to put in an elective patient in infarction, but could be taken in consideration when you have a stemming with thrombus involving the bifurcation of major bifurcations. And the result, at least in our result, demonstrates high success rate, not complications, not post-rotations, and a good steamy flow. So I think that I can say thank you for your attention, and I hope that you will start to put some access our way. Okay, thank you very much.
Thank you, Dr. Fouladvand, and thank you for keeping to time.
Correct. Less time even dedicated.
With Dr. Ferenc, yes. So, questions on the access?
Question. So I also use routine access, and I believe in this concept. If there is a really suitable anatomy, and this is a really perfect device with good long-term follow-up data. So we do this routinely in our catheter. Do you have cases with losing of access in the way, whatever? Sometimes it can happen.
You mean unsuccess of the procedure?
Yeah.
Well, in set
So
of
I
these
know
10
such
patients,
cases are-
no. But in the elective patient, because I have something about 45, 50 patients up to the moment with access, even I presented at TCT, problems with the access. There are some problems. It's not an easy stent to put in. It's not a normal stent to put in. There are problems with, sometimes you have to prepare well the vessel, the bifurcation. Sometimes you cannot enter in the bifurcation. You enter, you come back, you open it, but you're not able to enter the bifurcation because there's some blood, or you have to be careful with the angle. Sometimes you have to put the second wire in the side branch. Sometimes you cannot remove the stent from the side branch because you open it a little bit quickly. For example, I presented a PCR case like that. I started to open the stent, the patient went to the ischemia, so I was very quick. I arrived at the point of no return, and I was not able to remove the stent before the bifurcations. I left there in the LAD after the bifurcation, because at the end of the things, it's a stent. If it's not a bifurcation, it behaves like any other stent on the artery. So I have to recross extend to stand the side graft. So there are problems with this technique. Need experience.
No. Okay, so thank you for patience, thank you for answering, thank you for all speakers this quite long session. So I would like to invite